Good afternoon. I'm really delighted to welcome everyone to our Community Our Health, which is a town hall series to share ideas about health, prevention, and treatments that impact our community. My name is Betsy Shenkman, and I'm the chair of the Department of Health Outcomes and Biomedical Informatics. And I also co-direct the University of Florida Clinical and Translational Science Institute, and I'm the Associate Director for Community Outreach and Engagement at the UF Health Cancer Center. And I'm going to be your moderator for today's town hall. Today's town hall will be focused on a discussion about preliminary findings from a study that we're conducting looking at telehealth outcomes, social vulnerability, and chronic conditions. Specifically, we'll be looking at mostly today type 2 diabetes, but our study also includes hypertension. And today we have panelists who are involved in the study team and also from One Florida Clinical Research Consortium. And I would like them to introduce themselves. And I'm going to start with turning it over to Dr. François Modave.
Good afternoon, everyone. I am François Modave. I am a professor in the Department of Biostatistics and Data Science at UT Health Science Center in the El Paso Regional Campus, and I was a faculty at UF until very recently in Dr. Shenkman's department. And I'm delighted to be here and present our project.
Wonderful. And I'd like to go next to Tianyao Huo.
Hi, good afternoon, everyone. My name is Tianyao Huo. I'm a data analyst in the Department of Health Outcome and Biomedical Informatics at UF. I've been with UF for more than 10 years. I'm also a PhD candidate in medicine, concentrated on health outcome and implementation science at UF. It's my honor to be here.
Thank you. And I'd like to go next to Joshua Dorbu.
Good afternoon, everyone. My name is Joshua Dorbu, and I'm a research coordinator within the One Florida Clinical Research Consortium. My background is in public health, and I'm truly excited to be here and happy to serve as the project manager of this grant.
Thank you. And I'd like to also turn it over now to Troy Donahoo.
Well, thank you, everybody, and greetings. It is truly an honor to be here. I'm Troy Donahoo. I'm an endocrinologist here at UF in the Department of Medicine. And my role on this project has been somewhat as a content expert, but also as part of the data analysis. It's very important work looking at disparities, especially in my world around diabetes care. So thank you all for being here.
Wonderful, thank you. And again, my welcome to everybody. Just a couple of brief items in terms of how you can become engaged in the conversation. Please click on the question and answer button on the bottom of your screen to send in questions throughout the town hall. And Joshua will be tracking them for our panelists. And at the end of the presentation, we will take questions and have discussion. And so I'm really delighted to start with the first segment of the presentation that will begin with Joshua Dorbu and Troy Donahoo sharing a background and an overview of this telehealth project.
Thank you, Dr. Shenkman. Before we get started, I'd like to go over a brief walkthrough and overview of what you can expect from the entirety of this conversation. And first, we'll begin with an overall study background within the context of COVID-19, as well as telehealth in general. We'll review the why behind this project and the overall purpose of our research by way of our research goals and objectives. We'll also talk from a data perspective about who is using and perhaps who is not using telehealth. We'll also introduce the concept of shared decision-making and the potential impact that patients can receive from telehealth by way of shared decision-making. And last but not least, we very much hope to hear from you all as an audience with regards to what feedback you may have with this project and what you may want to learn about telehealth moving forward. And so before we segue into the study background, I would like to introduce and invite my colleague, Dr. Troy Donahoo, to discuss a brief overview as far as the origin of our study and a first-person perspective into how clinicians as well as health systems transitioned into telehealth in response to COVID-19. Dr. Donahoo.
Thank you, Josh. It's now been almost 2 years, but it seems like yesterday, when COVID first emerged and we had no idea what it was or how it was transmitted and all. So it was March 15th of 2020 when we first saw COVID emerging in Florida. And then the next click is between March and May, we had some issues, or we had the initial response, which was to stay at home practices were encouraged. And as many of you remember at that time, that included most of outpatient medicine. Going on in July of 2020, the restrictions were lifted, including restrictions on much of the medicine face-to-face clinic visits. And then moving forward to the next slide or next portion, late August, July, was when we had our first major surge in the US. The next surge we had was in December to January, which hit us a little bit harder and carried over a little bit even into they're definitely carried over into the springtime. And then the final thing is today, we're looking back to measure the impact of telehealth over these periods of time. But remember, as we talk through this, that we planned this study way back in the spring, summer of 2020, when we had no idea what was coming. So there's a lot of opportunities for us to look at other things or to understand things differently. So on the next slide, and one more click, I've actually been indirectly involved with telehealth since back in 2014. I've been here at UF for 5 years now, a little over 5 years. But prior to being here at UF, I worked at what used to be called an HMO, Kaiser Permanente in Colorado in the endocrine division. And we had a population of patients throughout the state of Colorado that we had to outreach to get them both medical care and follow-up without them having to drive 3, 4, 5 hours to Denver. In addition, it being an HMO type system, it wasn't as focused on fee for service. We had to see them visits. And so we had started in 2014 with some true telehealth visits, but it didn't really take off. Then the next click is just before COVID, we were sticking our toes in the water here at UF in the Department of Medicine. There were 1 or 2 divisions that were looking at telehealth, kind of experimenting with it, but obviously it hadn't really started. We really wanted to in endocrine, but we hadn't got up and running. Then we did basically a 180-degree pivot from several of us wanting to do it, but not knowing what to do, to it going to all telehealth. And interestingly, for us, covering both the outpatient, which was a more traditional model of telehealth, so to speak, but given the lack of PPE and the uncertainties around COVID, our inpatient clinical consultation also went to telehealth for a few weeks to months as we improved our situation as far as PPE and all. The next click is mid to April is when we transitioned back, especially to both inpatient and outpatient, to kind of a mixed model, but depending on the division and the structure, some transitioned very fast back to face-to-face, and others kind of stayed on a slower pace. That big arrow there underneath is where we put this grant together. So just for perspective, we were still not sure how things were going to go at that time. For me personally, around that time, I had 1 half-day clinic of telehealth. It started with Zoom and Doximity, and we've since transitioned to using MyChart, so it's part of the REHR with it. And then the next slide is, as of today, I have still have one clinic with 3 or 4 patients a week of telehealth, but the rest is face-to-face. In addition to diabetes, I also manage obesity, and several of the anti-obesity medications or controlled substances, which cannot be prescribed by telehealth, which limits some of the patients I can see. But kind of this has been my experience, and I think it's pretty common with the others. We've had challenges, especially with connectivity and with I tend to have more no-shows with telehealth, but other providers do really well. And then finally, just for perspective, in October of 2020, rather, in Shands Hospital, we had numbers of COVID positive patients in the 20s. In November, we had gone up to the 40s. In August of last year, we were over 200. And then by September, down to in the 80s, 90s. And now I made this a couple of days ago when we were in the 160s. Now we're back over the 200s again. And so you can see that it's been a waxing and waning in the hospital as well as with clinical with respect to telehealth. And now I'll turn it back over to Joshua to talk a little bit more about the specifics of the aims of this study.
Thank you very much for your insight, Dr. Donahoo. So our research effort is a mixed methods approach with the overarching purpose of quantifying the effects of the ceasing of in-person clinical visitation and the subsequent transition and increase of telehealth use amongst patients with differing social vulnerabilities. And we hope to achieve this through 4 project aims, the first of which being quantifying the effects of telehealth on disease control. And we are focusing on primarily type 2 diabetic as well as hypertensive patients and overall telehealth healthcare use. And our second is comparing the effects of shared decision-making and care between patients who've received telehealth visits in contrast with patients who have received in-person clinical visits. And our next one is comparing the implementation of telehealth across different health systems using in-depth qualitative interviews from clinicians and respective health systems leaders, and also data reports from our One Florida clinical partners. And then lastly, sharing our findings and any lessons learned from our study. And so what is the overall significance of this study? And what is the overall importance of it? Well, first, we can start from the large-scale health systems response to COVID-19. Early COVID-19 restrictions led to an increase, of course, of telehealth use modalities. And now, with the relative acceptance of telehealth and virtual visits, it's very likely that telehealth is going to be in some way, shape, or form a mainstay in healthcare delivery moving forward. We are also focused on type 2 diabetes and hypertension because they are 2 of the nation's most prevalent chronic conditions, and patients with these conditions are at a significantly higher risk of COVID-19 mortality. Of course, telehealth did exist before the COVID-19 pandemic, and in doing so, there was early evidence supporting telehealth as far as improving health outcomes. However, these studies were done so in very small and very controlled settings. However, there exists an opportunity now to explore telehealth in a real-world context and a much larger scale. And lastly, the potential for COVID-19 to worsen health disparities moving forward. It's been well documented of COVID-19's disproportionate effect on vulnerable groups, whether it's based on race, ethnicity, age, as well as geographical location, for instance, rurality versus urban living. And another disparity also exists, and that's with respect to technology and what we call the digital divide. And so we ask ourselves, are certain groups at risk of marginalization because of lack of technological capacity or lack of internet access? Or on the other side of the equation, are patients able to receive more access to care if they were experiencing barriers related to what we call social determinants of health, for instance, a lack of transportation or a wide distance between themselves and their provider? And so at this time, I would like to acknowledge the study team under the leadership of Dr. Shenkman, Dr. Modave, as well as Dr. Carrasquillo, who represents the University of Miami and the UHealth health system. Our co-investigators are also as follows, and you'll also hear the opportunity to hear from Tianyao, our data analyst, as well. Of course, myself as the project manager, and I would be remiss if I did not acknowledge the Agency for Healthcare Research and Quality, or AHRQ, as they are the grantor of this effort. And so thank you so much for your time, and I will gladly pass it to Dr. Shenkman and Tianyao for the next segment.
Wonderful. Thank you, Joshua. So let's go to the next slide. And Tianyao is going to bring those up. While Tianyao is bringing up the slide deck, you noticed on the last slide that there was a series of locations. And one, Florida, is a clinical research consortium that was developed under the University of Florida Clinical and Translational Science Institute in 2014 and received funding from PCORI, the Patient-Centered Outcomes Research Institute, in 2015. And we have partners throughout the state of Florida, ranging from its northernmost point, Tallahassee Memorial Hospital in Tallahassee, to UF Health, all the way down to the University of Miami in the south. So we have 12 health system partners throughout Florida, and recently added the University of Alabama and Emory University. So this study is really leveraging a very large set of electronic health record data that our partners submit to us every month. And this has really allowed us now to basically leverage what essentially could be called a natural experiment to look at the effects of telehealth with individuals with type 2 diabetes and or hypertension. And so this allows us now to really have great racial and ethnic diversity in this study, as well as great geographic diversity, to begin thinking about the potential disparities that Joshua mentioned during his presentation. Let's go to the next slide. So overall, we are still in the midst of this study, but this study is a little bit different than many grants in that the Agency for Healthcare Research and Quality wanted to make sure that we were releasing information throughout the study period so that we could be informing our colleagues, both researchers as well as clinicians. Stay back where you were, Tianyao, if you will.
Yeah.
It's on the effects of telehealth. And so one of the things that we need to do before we can even begin to look at the outcomes for patients that are receiving telehealth is we have to identify who the patient populations are. We have to leverage electronic health record data, healthcare claims data, in an observational study such as this to identify the patient populations. Next slide. So to identify the patient populations, we have in this study, we have our immediate goals that will lead into our overall longer-term goal of the study. So in terms of our short-term goals, there are algorithms that have been developed nationally and tested nationally to identify patients with type 2 diabetes or hypertension. And these algorithms typically rely on healthcare use alone, that is, do they have healthcare visits and an associated diagnosis of type 2 diabetes or hypertension? Or more refined algorithms also include information about what medications the patient's on, as well as particular lab values that they have. So for example, in the case of somebody who's a diabetic, there would be information if you were looking at lab values about hemoglobin A1C, or if you were trying to identify somebody with hypertension, information about their systolic and diastolic blood pressure. We won't be going into the technical details of these algorithms during this presentation, but we're happy to provide those on request. One of the things that we were concerned about in identifying the patients is the potential to introduce disparities very early on. So for example, if someone has restricted access to care, and maybe they can go for their clinic visit, they have a diagnosis of type 2 diabetes or a diagnosis of hypertension, but maybe they cannot get their medications. Maybe they can't go get their labs done. So we wanted to understand, are we introducing any biases or disparities in how we in the patients that we identify using different strategies? And so our very first step was really to look at any disparities, whether or not they exist, and Tianyao will be presenting about that. The next thing we wanted to do was also just very simply describe who are the patients who did and did not use telehealth services. And then that feeds into our longer term goal, where we are leveraging this natural experiment and using a variety of statistical techniques to look at clinical outcomes, including hemoglobin A1C control, as well as blood pressure control. So what we'll be talking to you about today are the short-term goals and analyses that we've done that we'll be using to feed into our longer-term analyses. Next slide, Tianyao. So let's go to the next one. We're talking about identifying the patients. So in terms of the sociodemographic characteristics of the patient population, we identified patients who had 2 or more healthcare uses in the outpatient setting, or 1 inpatient stay. They had type 2 diabetes or hypertension diagnoses, or both. We also looked at a series of medications that might indicate that a person has type 2 diabetes or hypertension. And we also looked at lab values. And in doing so, we identified almost 700,000 patients for inclusion in our study using electronic health record data that's submitted to us every quarter from our One Florida clinical partners. And one of the things that you'll see is that we have 56% are female. We have the majority that are either Black, Hispanic, or classified as other. 45% are white. And in terms of the urban-rural breakdown, the majority of the participants that we included in this observational study reside in urban areas. And then you can see the numbers on the rest of this graph of those that have type 2 diabetes, hypertension, or those that have both. And one of the things that's common across all of this is we have more females included. We see that people who are white in general are under 50% of the population identified, and the majority are residing in urban areas. And there are some, because of lack of zip code information and other things needed for geocoding, we were not able to determine whether or not they were in an urban or a rural area. Next slide. So in terms of assessing the disparities, we will focus today only on type 2 diabetes, even though our study does include individuals with hypertension. But today our focus is on type 2 diabetes. So as I mentioned earlier, there were different definitions or algorithms that are available nationally that researchers used and that we included in this study. All of the definitions require that someone has access to care. So the first one is what we call a healthcare use definition. And that one is 2 type 2 diabetes outpatient diagnoses within 18 months or 1 inpatient stay within 18 months. And it excludes emergency department visits, as well as diagnoses associated with ancillary services, such as ordering labs or ordering radiology. And we exclude those because we want to have some stability in terms of, not including rule out diagnoses or uncertain diagnoses that often are associated with ED visits or ancillary service use. We have a medication-based definition that requires an outpatient visit combined with an anti-diabetic medication prescription within 90 days. And then we have a laboratory definition that also involves some healthcare use and a hemoglobin A1C value of greater than or equal to 6.5. So those are the 3 definitions that we were working with to identify patients. And again, our very early question is, do these definitions yield any biases or differences? So this is the part where I'm going to turn it over to Tianyao to describe the study a little bit further. And to go into, we won't describe the statistical analyses in any depth. Again, for those that would like more information about it, we are happy to talk about it, but we wanted to look to see if we have racial, ethnic, gender, and or geographic disparities in how we identify patients in terms of the algorithms used. which is very important because if we're introducing any disparities early on in our study, then we may not really be able to draw the right conclusions or make strong recommendations about the outcomes associated with telehealth use. And with that, I'll turn it over to Tianyao.
Thanks, Dr. Shenkman. So from those statistical model, which is a multinomial logistic regression, we created those plots. And as you can see that the outcomes is whether a patient was identified by either the healthcare use or medication definition or lab definition, or both the medication and lab definition. And what we found is, as we expected, most of our patients were identified by their health use definitions. But we also find that in Hispanics, those are living in a rural area with the red line here, is more likely to be identified by the medication definition compared to the blue line here, those living in an urban area. And the similar pattern we'll find in non-Hispanic white, but the magnitude is the difference, rural-urban difference are much smaller. And we did not find the same pattern in Blacks. Looks like there's very little disparity between urban and rural residents in Blacks. And finally, in those patients with other racial ethnicity, most of them live in a rural area or identified by the either the healthcare use definition or medication definition, but not the labs. And finally, the question we ask is, who uses the telehealth? We compare the disease status of those among those who used or did not use telehealth. What we found is those who have type 2 diabetes only is more less likely to use telehealth. That's 11% versus 19%. We also found those patients with hypertension are more likely to use telehealth. That's 67% versus 59%. And those patients with both diseases didn't seem to have much difference. We also compared social demographics. We found females are more likely to use telehealth. That's 61% versus 49%. We did not find much difference among Hispanics or Blacks. We did find non-Hispanic white a little less likely to use telehealth, as 43% versus 48%. Patients with other racial ethnicity are slightly more likely to use telehealth, 17% versus 13%. We did not find much urban-rural difference among those who either use or did not use telehealth. Now I want to talk about the next step. So first, we want to enhance our understanding of the biases in who and who is not identified by different definitions. Second, we want to consider the trade-off in precision, identifying those individuals by adding those medication and lab values versus excluding those who may not have the access to care, thus did not have those data records in the EHR system. Finally, we want to refine the analysis who and who did not use telehealth, and we want to examine the outcomes such as clinical outcomes, HbA1c, and blood pressure. That's all I have. I want to thank you so much for your time. I want to turn this to Dr. Modave.
All right, so let me share my screen.
Sure.
Can everyone see my screen?
Yeah, looks good.
All right. So I'm going to talk about the second aim of this project, which focuses on the impact of telehealth on the shared decision-making aspect of clinical care. And it is an exploratory analysis, and I will explain why, and I'll talk a little bit about some of the work that we just started. But first, I will talk a little bit about essentially what shared decision-making is and why it matters. I'll talk about telehealth and shared decision-making and what we're exploring in terms of the impact of telehealth on the shared decision-making process. And I will talk about shared decision-making in a telehealth context and social vulnerability. And essentially the question is, do variations vary? I know it's written a little bit facetiously, but the idea is that do we see variations across different groups of people from a shared decision-making standpoint when we transition to telehealth? And of course, as my colleagues have pointed out before, we'd love to have some feedback and questions that you may have about this part of the project. So shared decision-making, what is it? So the definition is a collaborative effort between a healthcare provider and a patient to reach an evidence-based decision pertaining to the patient care while aligning with the patient values and preferences. And it's essentially a shift in the medical paradigm where we started from a more paternalistic approach to medicine, where physicians were really telling the patients, this is the best course of action for you, regardless of whatever belief or preferences or values you may have, to a couple of years ago, a more explained medicine where it was, this is the best course of action, but these are the reasons why. And more recently, the focus has shifted to a shared decision-making process where patients and providers discuss what the courses of actions are and ultimately decide together how care should be occurring. And so essentially, there are two main components to shared decision-making. The first one is risk communication. The provider provides evidence-based information on the pros and cons of the care. And second, values clarification, where patient and provider reach a common understanding of what matters the most to the patient related to the specific care. We are interested here in chronic conditions, and the shared decision-making process varies fairly significantly across clinical circumstances. For instance, there is very little shared decision-making process if you're in the ICU with no one around, because there isn't much discussion that can occur between a patient and a provider, or other more extreme circumstances that way. But in the case of chronic conditions, the shared decision-making aspect is critical because patient-centered care is essential to proper management of chronic conditions like type 2 diabetes and hypertension. So in the context of our study, shared decision-making is really important to manage those conditions well. So we are interested in shared decision-making, and the first question is, how do we measure it? And there are multiple scales, validated scales that exist, but for this project, we focus on SDMQ9, which is short for shared decision-making 9-item questionnaire, and SDMQ-Doc, and I'll talk a little bit about the two documents. But the first one is a 9-item questionnaire with obviously 9 questions and a Likert scale with 6 possible scores from completely disagree to completely agree. And the SDMQ-Doc, and that's one of the reasons we're interested in this specific scale, the SDMQ-Doc is the counterpart of the SDMQ-9 that is given to the provider who worked with the patient. So oftentimes, SDMQ9 can be given to a patient alone, but what you can do is give SDMQ9 to a patient and SDMQ-Doc to the treating physician. So you're really looking at the dyads and how the shared decision-making process is perceived on both sides of the clinical relationship. So the next question is, what do we know about shared decision-making? And the reality is we don't know a lot, primarily because shared decision-making questionnaires are typically not collected in clinical practice. So we don't have a lot of information. We don't have a lot of understanding of how patients feel about the shared decision-making process, nor do we have a lot of information about how physicians perceive it. From a telehealth standpoint, we have even less information. We actually don't even have the development of a scale that would be suitable for telehealth. Right now, we're not really sure whether we can use a traditional shared decision-making scale to assess shared decision-making for telehealth specifically. And finally, we'd like to see what happens with vulnerable populations. So we have very good evidence that social vulnerability is a risk factor across the continuum of care. But we'd like to understand what happens when we switch to telehealth in the shared decision-making process with people with social vulnerability. Do we see even more of a gap increase in terms of clinical outcomes and patient satisfaction, for instance? Why is this important? It's important because understanding if and where telehealth is suboptimal helps us remedy some of the issues. And so you can think of issues like internet access, complexity of the system being used for the exchange, and how the changes in interaction with physicians occur when we use telehealth. Eventually, it also provides insight on the use of other technologies in the future or very proximal future, things like virtual human technologies. I've seen that in the participants in the today's meeting, we have a couple of folks I work with on virtual human technologies for cancer screening, for instance, but also things like mobile health and other more recent technologies for care delivery. So we have two studies. The first one is within the One Florida research consortium, and it's a cross-sectional view of telehealth versus face-to-face. And we're comparing two things. We're comparing face-to-face versus telehealth in terms of shared decision-making, but we're also comparing different groups based on social vulnerability. So we're interested in the comparisons between the telehealth and face-to-face and the different groups and how they are affected. So in the study, we're randomly selecting 4 groups of about 400 folks, patients, one for each of the social vulnerability quartile. And ultimately, we have a target of 150 per group for the analysis. And for that specific study, we are only looking at the patient side because it's exploratory in nature, and given the time frame of the study, it would be difficult to do both SDMQ9 and SDMQ-Doc. And we're also using the CAPS questionnaire for that specific study. Then when we started asking our clinical colleagues, well, we'd like to do this study and collect information about shared decision-making, we actually bumped into a little bit of a problem. Everyone on the clinical side is really overburdened with the pandemic. And essentially, physicians are stretched thin. And the bandwidth was not there to really help with the collection of data from patients when they come for visits for the management of type 2 diabetes and hypertension. So we decided to look at, since it's exploratory in nature, and we have a system in place at UF to collect some of this information, we decided to look at, okay, at UF, what do we have? And we use the integrated data repository and I2B2 and the consent to share selection process, which allows us to recontact patients for research purposes and ask questions and whether they're interested in a study. And we developed a survey to see patients' experiences with respect to shared decision-making over the last couple of months. So we use I2B2 and consent to share to contact them directly after IRB approval. And we use the same two questionnaires. And so we're collecting this information prior to collecting information from the One Florida cohort to see what the experiences are in terms of SDM. So we literally had the survey live, I believe, 2 days ago. So it's very recent. We have about 2,000 patients that were contacted, but we had a few patients already answering the questionnaires. So obviously take all the results with a grain of salt because we only have 1/40th of the patients having returned the questionnaire, but we have 52 patients. The median age range is from in the 65 to 74 age bracket. A little bit more women than men have answered. That's to be expected. That's tends to be the norm when we collect such surveys, and white are overly represented as expected within the Gainesville IDR. Everyone has, or a large percentage of the patients have experience with telehealth, and a large percentage has a good experience, at least a good experience with telehealth, indicating that it's at least as good as a face-to-face visit. Granted, we had even less answers on that specific question compared to the entire 52 patients that have answered. Nearly all of them have access to the internet, and nearly all of them have a smartphone. And to indicate why we need to take those results a little bit with a grain of salt is the group is fairly biased for now, as we have a very large percentage of them that are with at least a 4-year undergrad degree or a graduate degree. We have 30 patients out of 52 who have at least a bachelor's degree or a graduate degree. Specifically to the shared decision-making aspect, the overall results so far indicate that the shared decision making is very positive. So if you look at the numbers on the rightmost column, the first one indicates strongly disagree, completely disagree, sorry, then strongly disagree, somewhat disagrees, somewhat agrees, strongly agrees, and completely agree. And so as you see, nearly all the answers are clustered on the either strongly agree or strongly disagree. And so their patients have their experiences is that doctors made it clear that a decision has to be made. They make it clear that the doctors have indicated that they would like to know whether the patient wants to be involved in the decision-making process. The doctors indicated that there are different treatment methods. They indicated the advantages and disadvantages. The physicians indicated what the content of the information and how patients understand that information. And they largely indicated that they wanted the patient to explain which treatment option they would prefer. And finally, they discussed pros and cons, and they reached a conclusion together in terms of how to proceed. So far, it's very, very positive. The question is whether this is going to remain once we have a larger number of patients that have answered those questions. And this is it for the shared decision-making aspect of the project.
Wonderful. I want to thank all of our panelists We are really excited about the next steps in this research. As I mentioned, this is just the very early phase. So I know we have several questions in chat. And I think, Joshua, were you going to guide us through some of these questions?
Yes. So the first question I see is, and I hope my audio is working. I've received word that it was a little bit spotty at times, so I hope it's improved. What can the disparities in COVID-19 incidents be attributed to, other than lack of access to vaccines, since access to care, lack of transportation, and other barriers don't account for this? And I will toss it to Dr. Donahoo first.
So I could start from the medical side, but I think others will definitely have a better input as far as the social disparities side. But there are medical conditions. I know diabetes is one of the things we're specifically studying, as well as obesity, that are overrepresented in people of color, but also may increase the risk of catching COVID, in addition to definitely increase the risk of having more severe symptoms and a poorer outcome. So there could be some medical reasons based on this, but I think the real question might have been more around other social determinants of health that might be affecting that. And I'll let François or Becky chime in.
So just a couple of things, one of the beauties of having the large numbers that we have for this study, and as you'll recall, we have 700,000 patients from across our One Florida partners. But as we look at outcomes, and this isn't really, we do have information about whether or not the patients had COVID. So not only do we know if they had type 2 diabetes or hypertension, again, recognizing the limitations to the algorithms that are being used, but we also have diagnostic information on whether or not they had COVID, if they have other co-occurring physical or behavioral health conditions. So we are able to delve into looking at their outcomes, considering a wide range of factors, including health factors, but also social determinants of health, because everybody in our data set is geocoded. The majority are geocoded to a 9-digit zip code, which gives us a lot of information about census tract. So while the study is focused on telehealth outcomes for people with type 2 diabetes and or hypertension, regardless of whether or not they had COVID, nonetheless, we will know if they had COVID, and we'll have very important covariate information, including some of the very important social determinants of health, along with information about race and ethnicity and gender and urban rural location. So I think, overall, we should really have some very robust information that will arise from the study, but we're not looking specifically at who's getting COVID or not in and of itself. So why don't we go on to the next question, Joshua?
Sure. Our next question is, I've heard that some physicians and providers are less facile in Zoom than some of their patients, even older adults, and do not like online care. What do you know about how providers like telehealth? Is there a disparity among the providers themselves and thus the patients they serve?
And let me start with that as well, and then certainly Betsy could add to it and others, but that's a really great question, Linda, and an area that we're focusing on very much. We had a limited amount of time, could only talk about certain aspects of this study, but one major part of our funding was to do surveys, both with health plan leadership, as well as physicians, primary care and endocrinologists, to look into this question of their transition and how well their colleagues, them and their colleagues, were able to utilize telehealth. And you're exactly right. There are some of us who are not as good at telehealth as even some of our older patients who you would think wouldn't be. So we're in the process of looking at it, and hopefully we'll be able to have some reasonable data to answer that question. Again, as François said, it's been challenging with everybody dealing with COVID at the same time, but you want to add more, Betsy?
Yeah, and I also would like Joshua to provide some detail. Another member of our team, Ryan Tice, is not on the call today, but Ryan has been leading a qualitative component and working with Joshua to conduct interviews with clinicians as well as healthcare system leaders about their views about telehealth from a variety of perspectives, including, reimbursement, the feasibility of continuing it, concerns and barriers from a patient perspective, at least as viewed through the eyes of clinicians and the health system leaders. And Joshua can give an update on how many interviews were completed. He and Ryan Tice are in the midst of the data analysis right now. And we hope that this will be both an academic paper as well as an issue brief that we can release, because the idea is to coalesce and understand the telehealth from a variety of perspectives, certainly a patient perspective, which is absolutely critical, but also from the perspective of clinicians and health system leaders. So Joshua, I know you and Ryan did a lot of interviews, and maybe you could do just a brief update on that.
Yes, absolutely. So we have interviewed representatives, or we've interviewed 24 a combination, or 24 individuals, a combination of clinicians as well as health systems leaders. So 12 clinicians, 12 health systems leaders. And to the question of, do you know how providers like telehealth? So far, we've seen a wide variety of responses, and it's very mixed in approach. And so we're currently in the analysis process to really find some themes around general satisfaction amongst providers and health systems with regards to how telehealth has been implemented. And so we hope to share that information fairly soon. But it does seem to be quite a range as far as whether or not providers like or engage in telehealth, because there's factors like safety early on in the pandemic, where it just seemed like a much safer approach for clinicians and patients alike. And so those dynamics have also shifted moving forward as well. And so there's a lot to continue to decipher, and we're still very much engaged in that process.
We do have another question about, and I think François, if you could take that question, is there any research on whether patients prefer telehealth versus in person? And what would the main demographic differences be, if any? And I know we're not addressing preferences per se on telehealth, but I think the shared decision-making gets at that in a way.
Yeah, so that's a very good question. And so I read a paper recently where they were specifically addressing that question of patients' preferences in terms of telehealth. And the overwhelming response was that patients do like telehealth a lot because of the convenience, because of not having to go anywhere. I did not look at the details in terms of split across race and ethnicity and other possible factors that may affect how telehealth is perceived, but the telehealth component of care was viewed very, very favorably. Interestingly, that study was done even before COVID-19. So it was a study that was published in early 2019. So that indicates, I would suppose that with the associated risk of getting COVID-19 going to a doctor's office at the moment, I would assume that this shift towards preferring telehealth is probably increased even more now.
Thank you, François. There's also a comment about, can we have a copy of the presentations? We definitely will work with our community or health team on that. There are some additional, things that I want to make sure on the presentations. Again, I want to reiterate, this is a little bit different than a typical research grant where the funder does want us out there and talking about preliminary information. So I do want to reiterate that this is preliminary and focused on some of our initial goals of patient identification and the data that we are collecting. So I want to make sure that's appropriately well labeled on the presentation deck. And also we'll do some bullet points on the graphs that Tianyao presented, because I think it really is very important to note that, for example, the graphs show what we call intersectionality. So Tianyao was presenting, for example, if you're Hispanic and living in an urban area, and if we're relying on a laboratory-based identification algorithm, we have the potential to under-identify certain groups. And some of that could be that perhaps the data is not in the electronic health record. Some of it could be that the person didn't get the care and it was ordered, or it could be that the care was never ordered. So there could be a variety of reasons that we certainly want to explore, but we certainly know at the very least that we can be missing key vulnerable populations in our analyses based on well-developed and well-established algorithms. And that's something that we need to continue to address as we all work very hard to reduce disparities and achieve health equity. So we'll do a little additional labeling on the slides, and we'll work with our community, our health team, about how they make those available.
And I will add to this specifically with regard to Hispanic populations. We know that the information is not necessarily captured very well. It's not standardized across clinical practices. And I recall having discussions about this with Troy, but also with Eric Rosenberg, the chief of internal medicine, and with the former chair of family medicine, Peter Carrick. We don't capture it necessarily very well. And it's not necessarily standardized. And so we probably miss some of the Hispanic patients, or they're not labeled as such in the EHR. And so we probably need to do a better job at identifying Hispanic patients for accuracy.
Mm-hmm. Thank you, François. And we have one last question. I know we're drawing close to time. So this will be our last question. Is there any way patients can participate more in shared decision-making in terms of telehealth or in-person visits? I understand it can be complicated in terms of logistics for the clinic, especially specialty clinics. And maybe also, Troy, I think, if you could weigh in on that too, from your perspective as a physician, and maybe François as well.
Yeah, I can start. I think, as François said, we are just at the beginning of even understanding shared decision-making and how to better optimize it. I think there's many of us, especially with diabetes and metabolic disease, where it's critical to have shared decision-making, that are trying to optimize it. But I think the best I could say is oftentimes, unfortunately, it's going to be the patient having to educate their provider and to say, what are the other options, or this is what I think, and trying to move it forward as we try to understand it and go from the top down with it. But I know that's not a very satisfying answer, but this is a critical field, a critical part of medical care that we're trying to get past that paternalistic viewpoint, but there's a lot of older physicians that are still stuck there. So François, what are your thoughts?
I entirely agree. I would say that patients who already have an interest in the shared decision-making aspect of care could even talk to their family members and friends and others, and just say, ask questions, and what are the other, get others to know that it should not be paternalistic. It should be a shared decision-making process. So get your friends and close ones to ask questions, to get involved in the care. I think that'll go a long way. And yes, it puts the onus on the patients rather than the clinical practice, but I don't have an obvious answer right now yet.
Thank you. So Joshua, do you want to close us out for today? I think we're 1 minute away from time.
Sure. I believe we've wrapped up the questions from the Q&A as well as the chat. I'd like to thank everybody for taking the time to attend this conversation and providing feedback as well. We've truly enjoyed the opportunity to present some of our preliminary findings and hope to do this again very, very soon. So thank you so much again.
Thank you.